right, Dr. Albert Brady, his second time on my podcast here. So excited to get you back. The first time we had you on, it was a group interview with myself, Nick Lalani, and Dr. Baldwin, talking about like kind of euthanasia. But today we're going to talk about something more personal, kind of your career. And I guess kind of the main question that this is all centered around is you've obviously, you're an oncologist. You've saved, I'm sure, countless lives, so many lives, but also you've had to deal with, diseases that have totally succumbed to the person. And when in your career have you really wanted, I don't want to do medicine anymore, I'm over being a doctor, or really kind of that ultimate sort of burnout depression that we always hear? And when did you face that?
Probably about 5 years in.
Okay.
To practice.
Now, so right out of residency, or once you were on your own?
Once I was in practice.
Okay.
Once I was in practice, probably about 5 years into practice. In residency, there's a lot of support. You have faculty and your fellows, and it's all new.
Yeah.
But of course, when I started, it was a couple of years ago, and
yeah, one or two, and what we could do for patients was limited. And one of my major motivations for getting into it was to make patients comfortable, because my grandfather died this terrible death of metastatic prostate cancer. He had awful pain for months, and I didn't want, at least the people I took care of, to go through that. Yeah.
So I thought there were maybe 3 things that I could do no matter what. I could keep them from throwing up, I could keep them pooping, and I could keep their pain under control.
Yeah.
And about 5 years in, I had a young lady who was my daughter's age.
And so how old at that time was that?
She was probably 23 or 4.
Okay.
And she'd actually pledged at the same sorority that my daughter had pledged.
Oh, yeah. Okay.
They were both going to Oregon State. And she had metastatic melanoma. And, we pushed things back for a little bit. And then it was clear that her disease was out of control and I didn't have options. And she developed this hypervomitosis syndrome.
Okay.
And at that time, we didn't have the drugs we have now, but we had a fair number of drugs, Reglan and Compazine and so on. And I could not control her nausea and vomiting. I absolutely could not control. I tried multiple drugs, combinations of drugs. I couldn't control her nausea and vomiting. And I felt a tremendous kinship with her, because she was my daughter's age, paternal kind of kinship. And she died pretty miserably. And at the same time, in a 24-hour period of time, 4 other people that I'd been struggling with and fairly close to died. So I had 25 deaths in 24 hours.
Wow.
And it happened on a Thursday. So I went to work on Friday, and over the weekend I became profoundly depressed. Just, if you haven't been there, it's hard to describe it to somebody, but just profoundly depressed. And I got up Monday morning to go to work, and I realized that I just could not go to work.
And so, if we could pause here so depression, of course, has many. I feel like everyone can relate to depression, but it looks so different to so many different people. So, when you were in that state of depression, did you turn to the whiskey, or did you just isolate yourself completely, crying completely? What I guess was that experience like for you?
I was isolated and crying almost continuously.
Yeah.
And I got up Monday morning, shaved and put on a tie and started crying. And I said, I just can't do this.
Yeah.
So I waited until 8 o'clock when the practice opened, and I called them and said, I'm not coming in, and I don't know when I'm coming in or if I'm ever coming in. And I'll call you and let you know. And I had some friends who had become Buddhists and who had moved to the Buddhist Abbey in Northern California, Mount Shasta. And it was the only place I could think to run to. So I drove down there and spent a month with them at the Abbey. And there was a lot of, she was a social worker who I'd worked with. And they had a couple of girls, and he was a photographer, but had sort of become a jack of all trades, built their home, and was actually building their home when I was there. So I worked with him building the house and went to the Abbey, and we meditated, I don't know, 3 or 4 times a day, and gradually things came into focus for me. And I've always had a hard time describing the transformation, but after that, I had an appreciation for life and for my skills, but more importantly, my limitations. And I came back to practice, and I think I was better than I'd ever been. And it was now, I won't say easy, but possible to deal with death and dying and misery and be engaged and be part of that and help with that, and not what comes to mind is be trapped in it, or be devastated by it. I think it's what Ulcer meant by equanimitas, that you're not walled up or separated from the patient in the process, the professional wall people talk about, but you have the capacity, sometimes I think about it like an electrical phenomenon. You have a capacity to ground that out, that you can take it and sort of send it to ground and not be overwhelmed by it, or overwhelmed by being engaged in or part of the process for these patients. Arriving at that point really made it possible for me to continue to practice oncology for another probably 30 years. The response, I have to say something about the response to the community. It was all medical community that are relatively tight-knit. It was in Portland, but it was still, I was at one hospital primarily, and I had enjoyed a pretty broad referral base from most of the physicians at the hospital. And afterwards, there were people who wouldn't speak to me.
Wow.
There were people who would never referred to me again. People who actually avoided me in the halls. And I think that, I'm not sure what that was all about. I think a piece of it was that I'd somehow failed the profession, that I'd walked away.
Yeah.
And that they didn't want to be around a guy who couldn't cut it. But a piece of that, I believe, was that they themselves had never dealt with it and didn't want to be around somebody who didn't want to be challenged in any way. I remember being in a group of docs who were talking about life, and urologist was destroyed by the fact that he'd operated on a 90-year-old guy, and the fellow had developed complications and ultimately died. And as a urologist, a lot of what you do, and you can pick and choose obviously, but a lot of what you do is pretty straightforward, and you're not going to do it on people who you think are going to die. And he was just destroyed by the fact that he'd had a death on his service. I mean, truly, in some significant personal agony over that. And I looked at that and thought, I couldn't afford that.
Yeah.
Because there were certainly deaths every week, and I can remember another stretch after my time at the Abbey where I had 15 deaths in 14 days.
Wow.
So fortunately, oncology is different now. Fortunately for the doctors and the patients, we can do so much more. You all, your generation, can do so much more. But you needed a mechanism, some kind of mechanism, for dealing with all the death and agony if you were going to do oncology back in the 80s, 90s.
So this transformation you went through, was it you starting to accept Buddhism as your faith? Did you kind of start to really practice Buddhism on a regular basis, or was it more the practice of more just meditation, just kind of being with your thoughts and your feelings? And so I guess how did that transition sort of happen? And for the next generation of doctors like myself and our classmates, how can we emulate something like that?
Yeah, as much as anything, I think it was the meditation. And deep in my heart, I'm a Christian, and I can't get away from that. And I thought, when I was sort of, if you will, experimenting with Buddhism, that maybe I would. But that isn't who I am. And one of the things that was rewarding for me was to discover the Trappists, who approach Christianity in a very Buddhist way. But I think it's the peace and quiet and contemplation that comes with meditation that allowed me to find a different place in my life, a different way of being.
And so when you had this next kind of really rough spell that you refer to, the 15 deaths in 2 weeks, were you able to handle that well because of that experience you went through prior in your career, or did that once again really throw you off the rails?
Well, I didn't go off the rails.
Okay.
I won't tell you it wasn't hard.
Yeah.
I wasn't distressed, day after day after day. But it was manageable. There's it's really hard to describe, Logan, but there's this sense that you've done the best you can. And I mean that in a really personal way. I was never somebody who kept a distance from patients. I didn't see the merit in that. And I guess the merit in that for some people, and I've known people who were pretty cool and distant physicians, it was how they survived emotionally. What I needed to do was figure out, because of the role I saw a physician being in with patients, particularly patients who are critically ill, I needed to figure out how I could be engaged with patients and families and still be okay myself. And that's what happened during that time away.
And then I guess the other question I have is, I know that becoming a doctor, it's going to be so stressful. And one thing through this podcast I feel I always say is a sense of community is the best way to handle these kind of challenges. So, when you took that step away kind of from medicine for a month, and you said part of that community you lost, in medicine. You used to be doctors that wouldn't refer to you anymore or ignore you in the hallways. But then did you find like a new aspect of a medical community that was much more accepting of these ideas, these religious practices, meditation practices, or how did you like adjust?
Yeah, it was interesting because there was a group of people who I don't know if admired is the right word, but respected me for what I'd done and how I'd come out the other side, and that I'd been able to sort of put myself back together so that I could continue to practice in an effective way and in a really humane, compassionate way. And I had to accept the fact that there were people who were made very uncomfortable for whatever reasons, whether they were personal or professional, with the fact that I needed a time out. I will tell you that most of those people, looking back, most of those people were surgeons. And for their part, you know, their relationship with patients is often, not always, but often pretty limited, and they can often pick and choose who they tend to engage with rather than having to engage with everybody that comes through the door. And that's not to be pejorative towards surgeons, it's just the reality of.
Yeah.
There are a number of, you know, there's an acronym now, NOPERS. Have you heard that?
I haven't, no.
No ongoing patient relationships.
Oh, jeez.
So there are a number of cubbyholes in medicine where you can be a noper. And I think for some people that's good.
Yeah, what they're looking for.
It's what they need, or yes. And I always had this fantasy from the time I was very young that I was going to be sort of the country doctor, you know.
Yeah.
I get in my buggy and go out to somebody's home and sit with them while they were dying. And
yeah.
Although I gave up the idea of primary care, actually fairly late in my residency, that's how I saw oncology, is that I was with those people. And it was the training program that I trained in too. I mean, I went to the University of Minnesota, which at that time was really committed to taking care of patients, doing what you could oncologically, but taking care of patients and managing their pain and nausea and depression and whatever came with the illness. You weren't there just to deliver chemotherapy or endocrine therapy. You were there to take care of the patient. And my two main mentors I really can't say that. I think the program as a whole was dedicated to that. It was a cornerstone of the way they taught oncology.
So as your career developed, I imagine, you know, you said the three principles that matter to you the most, the nausea, the pain, being able to poop somewhat normally, got maybe easier because the medications got better. But I also imagine, you know, as an oncologist, these treatments got much, much more expensive. And so I think that would be incredibly challenging as a doctor, fighting with all these insurance companies. But what issues did you face as your career evolved? You know, you developed these life skills to handle this stress, but I imagine it still wasn't peachy. It was always kind of challenging. So when else did you really kind of, you know, banging your head against the wall? Maybe you wanted to retire from medicine early, but, you know, you decided to push through.
Right. I would say that the toughest thing became dealing with insurance in a variety of ways, either approval for studies or therapies, or payment for therapies, or non-payment for therapies, and having to sit down with a patient and say, this is a deal, you know, it's $10,000 a month, and if you can do that, I need cash on the barrelhead, and if you can't, then I can't treat you, and I don't know where you can go to get treatment given your insurance or lack of insurance. And the biggest aggravation is having to get on the phone to talk to someone to justify something that the patient clearly needs. And there's a whole industry built up around that. And I can remember one call in particular where it was clear the call lasted like maybe 15 seconds. And it was clear from the beginning of the call that the doctor was going to approve the study and knew the study needed to be done, but somehow in how he gets paid or whatever, he had to talk to me. That's kind of a pathetic use of a doctor, him, and B, my time. And those things, I don't think I ever really got used to. It's one of the ways in which the system wastes physicians' skills and efforts. And I don't know that there's a better way. Part of the problem is that every payer has its own system. So there's not universality where you could say, I know this will be covered, no problem. The indications are there. Each of the payers wants their own person to check it out and be sure it's justified. It's just, I wonder if it's really, it takes a lot of time and money. It takes money in terms of the fact that you have to pay those people, but then it costs money in some way in terms of the time that is spent away from patient care.
Yeah.
And we hired people to try and deal with that, but there were times when they weren't allowed to, no matter what their skill set was. And sometimes they would get somebody on the phone and call me over, and I would say yes, and but still, I'm interrupted in the middle of a patient visit. It was aggravating.
So, we talked about meditation a little bit, but what other strategies did you use throughout your career to manage the stress, to have a balanced lifestyle, to be a father, be a husband, and be happy?
Yeah. Well, it was Miss Jean who taught me how to.
And that's your wife? My
wife, yeah. She pointed out to me that I was in charge. And if I wanted to go to a kid's game, then I just said I had the schedule. I just said on these Thursdays I'll be gone by X, and on this particular Thursday, because the game is 30 miles away, I'll be gone a little earlier. I was terribly freeing, because you're torn between trying to finish up and trying to get somewhere when the time is impossibly tight to do that, and showing up at halftime or whatever, or the beginning of the fourth quarter, and being there for the game, and then going back and finishing up. I mean, there was nothing wrong with doing rounds at 7 instead of 5.
Yeah.
And then the other thing that I think collectively she helped me realize was I came to a schedule that for me worked. And I'm sure it's different for everybody, but my schedule was a week off every 3 months, 2 weeks off in the summer, and 2 long weekends scattered somewhere in the middle of all that. We loved the theater, and we would leave on Wednesday and come back on Sunday and go down to Southern Oregon to the Shakespeare Festival and see plays. And one long weekend we'd spend with the kids, and the other long weekend we'd go by ourselves. So I had developed a system where I probably had maybe, and the holidays were important, the winter holidays were important. I developed a system where I probably had about 7 weeks a year off, and that clearly contributed to maintaining some equanimity in the course of the practice. You always had something to look forward to that wasn't too far out. And for a while, I actually gave a talk on, or participated, and I was part of the day-long seminar for oncologists on communications and coping, and in talking to a lot of physicians about coping, the one thing that I thought I found in oncologists who were pretty well balanced was they also found they needed time away. That time away was important. And I would say, no, I know that the cell phone was a disaster.
Yes.
And again, it was Gene who said, it doesn't have to be on, you know.
Yeah.
And you have partners, and they're trained, and they'll muddle through without you. And so before there were cell phones, I would usually call in like once a week and say, is there anything you need to know from me that, something that isn't in the chart, or a conversation I had, or a suggestion I might have for this particular patient. And cell phones changed that until I figured out I could turn it off.
Yeah. Use airplane mode for your benefit.
Yes.
Yeah. Well, so now I kind of want to take the conversation more into, so I feel the pre-med or preclinical years, the first 2 years, where you taught us so much. I enjoyed portions of that, but it is so, you get tests every day. It's very, I hate getting tests. I'm not a good test taker. But we have all of our student body right there. And it was really nice to have that community we could bounce ideas off of and just help each other. Now in third and fourth year, and then as we go off into residency, we're going to be scattered all over the place kind of thing. So part of the reason why I enjoy doing this podcast so much is to try to bring that sense of community back in some sense, through listening, through a podcast, whatever. But what advice, there's a Facebook page where I'm going with this. There's a Facebook page where people can essentially vent anonymously about what they're feeling. And so there's, let's just say, a fair amount of students who are really struggling right now in their third or fourth year. Maybe they're not enjoying clinic or patient care as much. They're freaking out about finding a residency. What would you say to those students?
Don't worry so much. I mean, I think that certainly what we see, even in third and fourth year students, is this anxiety about the boards.
Yeah.
And what you're doing is board prep. And the reality is that board prep that you do in January for June probably doesn't stay with you anyway.
Yeah.
And I think in your third and fourth years, diving as deep as you can into each case is the best thing you can do for your education and to be prepared for the board. So if you have an Addisonian patient, but you look at the differential and the physiology of the adrenal gland and so on and so forth, those are the kinds of things that are going to be on the boards. And so now you've covered that. And each patient, I remember when I was chief resident, I used to make rounds at like 9 or 10 o'clock at night just to be sure things were okay. And I was rounding one night, and the resident was complaining that they had admitted this alcoholic who was just a bum, and what a pain it was to admit somebody at 10 o'clock at night or so who was a bum and who was wasting his time. So I looked at the chart, and the guy, I can't even remember all the things now, but the guy was hyponatremic, and I think he was hypothyroid, and he had like 15 things wrong with him. And so actually engineered a grand rounds where I had 6 speakers talk for 10 minutes about one of each of these problems, and I pointed out that we only covered half of the guy's problems. And to recognize that every patient has tremendous potential to teach you, and not shove that aside, but to recognize it and take advantage of it, capitalize on it. I think your community becomes, one of the advantages I had is I was always in an academic center, so I always had interns and residents, and your community becomes the people that you work with on this rotation, interns and residents. And I had some rotations where things were fairly intimate, and it varied. Sometimes it was the nursing staff, sometimes it was the residents, sometimes it was the interns, or occasionally it was your fellow students, but a lot of times there weren't other students on the rotation with you. And I guess some flexibility and being social enough to recognize who's there for you and who will help you, who wants to help you, and take advantage of that and capitalize on that.
Yeah. Then I think the other big anxiety is people feel, oh, if I don't get this general surgery residency at University of Washington, my career is a failure and it's over. And there's so much anxiety that I feel is just self pressure on, no one's pushing you necessarily to do all this, but people freak out and they almost look at their life as a failure if they can't go be an oncologist at UCLA and follow in your footsteps, kind of thing. And I had this conversation with Dr. Englund the other night. It's, your success in life shouldn't be determined exactly by your job and your, I don't know. What do you think? What advice would you give to someone who is freaking out about the residency they may be placed into?
I think everybody freaks out. I don't know how to prevent that. In my case, I had listed Duke Medicine 1 and Duke Surgery 2, and Duke Surgery had called me and said fundamentally that they would accept me. And by the time the match came out, I knew that I didn't want to be a surgeon. I wanted to be an internist. And so I was freaked out that if I didn't get Duke Medicine, I was screwed.
Yeah.
I was going to be in a high-pressure surgical residency that wasn't going to really prepare me for what I wanted to do. I think that you have to be willing to accept the reality that most of us don't get our first choice, and you have 2 or 3 backups, and that they're all good, and that you're going to be board eligible at the end of that.
Yeah.
And that you're going to pass the boards. I think that I struggle with the whole concept of how we do boards. I'm not sure that it's healthy for anybody, frankly, but particularly for students. And I wish that would change, and I've written a couple of letters to that effect. We'll see whether it does over the long haul, but the reality is you all have to deal with the system that's in place right now. And I would say, through your 3rd year, as you figure out where you think you're headed, then in your 4th year, you have your audition rotations at 2 or 3 places, and you list those 2 or 3 places, and you lobby those 2 or 3 places, and you hope for the best. And if you're lucky, you get your first choice, but your 3rd choice is going to get you where you want to go anyway.
Yeah, yeah. So, myself, along with, I think, I could safely say a vast majority, almost everybody of the student body considers you a tremendous role model here on campus. I want to practice medicine. Once I get a few gray hairs like yourself, come back in maybe a more teaching role. I think that would be really a tremendous opportunity for me. But, looking at your life, I hope I can maybe take a month away and really take a break from medicine or in some capacity, but who knows if I can actually do that. But what values are the most important to you that you think I should try to emulate in order to live a successful life like you did in this world of medicine?
Well, you're very kind. Thank you. I would say that there were very few patients who I couldn't relate to or deal with, and those people were abusive to my staff, and I couldn't tolerate that. And those people had to find someplace else to get their medical care. For me, the key thing is something called countertransference. That is, you are what the patient needs you to be. And the sensitivity to figure out what it is this patient needs from me as their physician. And I really didn't have boundaries. I could talk with the sailors like a sailor, and I could talk with a 90-year-old lady who still wore white gloves before Labor Day. It didn't matter to me. Particularly when you're in a setting where you have to deal with all comers like the ER, the ability to subjugate yourself, not in a self-deprecating way, but in a way that allows you to relate in a very meaningful, tangible way to this individual patient at this moment. And I guess I would say that is one of the things that came to me from my experience with the Buddhists. That you're in this moment with this person trying to accomplish this goal or this set of goals. And that's all that matters. I think we all struggle with the clock, but I learned early on in my practice not to wear a watch because I was looking at it all the time, and the patients know you're looking at it. And there's clocks around. Yeah. You can figure out the time. So I decided that when I was with the patient, I was with the patient. And if it was 5 minutes or 10 minutes, great. That helped me get back on schedule. And if it was an hour, it was an hour because it needed to be an hour. And patients understood. I mean, my staff would always say, Dr. Brady's at 30 minutes behind or an hour behind, and do you want to wait or do you want to reschedule? Most people would wait. And patients understood what was happening. They understood that I was behind because somebody was in trouble, and that when they were in trouble, they would get the time. At least that was the patient population that I dealt with. The generations that you'll deal with may be different, but I suspect not very.
Yeah.
I think, again, as long as you're respectful of them, it's not that they're out in that waiting room for an hour and a half wondering what the hell is happening. Somebody's talked to them and knows what's happening. And, sometimes there were times when I had to go to the hospital. And so he's in the hospital, and he'll call us and tell us when he'll be back. And, what would you like to do? Well, I'll wait for half an hour, and then if he's still not back, I'm going to reschedule.
Yeah.
But it's the respect and commitment to the patient that were most important to me. And I guess the next thing was being sure that I was doing a quality job. And if I wasn't sure, I called somebody to find out, or check with a peer or something. And making sure that the people I referred to would do a quality job, or finding somebody else to refer to. I mean, the patient, what I want to say is the patient always came first, but in order to do that and to do it well, as we've talked earlier in the afternoon, you have to take care of yourself.
Yeah.
Or you won't be able to do that well, which should be your real mission, our real mission. Certainly was my mission.
Yeah. And one thing I've heard you say, in these hallways is, if you do ever see a colleague or a nurse, a subordinate, whatever it may be, who you think is struggling, try to put yourself in that uncomfortable situation of asking, are you okay? Or, really almost, it's much easier, I feel like, for someone to ask that uncomfortable question than for that person to really ask for help in some situations.
Yeah. So let me tell you a story that exemplifies that and was an epiphanal moment for me. I had a lymphoma patient, and, if we couldn't do anything else in the 80s, we had one more agent that we hadn't tried that might push the lymphoma back for a few days or a week or two, but was certainly going to cause toxicity, particularly in somebody who had been heavily pretreated already. And I had someone I was particularly close to, and I just told that the chemotherapy wasn't working and that we needed to change tactics. And I was sitting at a desk truly in agony, probably close to tears, about what am I going to do next, and what is the balance? How much harm am I going to do, and how much good am I going to accomplish? And the truth is, a lot of harm and not very much good. And this is somebody who I was close to, and what was I going to do? And one of the staff that I worked with, who knew the situation, walked up and put her hand on my shoulder and said, Albert, it's okay to let go. and that was the right answer.
Yeah.
That was the right answer. And, having somebody else give me permission to go back and say, the balance is just not here, and our focus has to be on quality and pain control and nausea control and making sure your bowels work and whatever else was wrong. Because if I tried to help, I'm going to make you sicker and maybe even hasten your death. So out of that, I recognized that we can isolate ourselves and feel like we have this tremendous responsibility. And having a peer recognize that, or for that matter, turning to a peer for help with that, can make all the difference. Not only to you as the caregiver, but to the patient.
Yeah.
It would have been absolutely the wrong thing for me to give that patient more chemotherapy. And having someone bring the right focus to the situation helped me, and that meant I could do the right thing for the patient.
Yeah. Well, I think that's a fantastic kind of story to end on. Dr. Brady, this was a real pleasure for me. Thank you so much for coming on the podcast for a second time.
Yeah.
This is pretty cool. Thanks again. I'll release this right around the new year. So happy New Year for all the listeners. And thanks again. This was tremendous.
Always a pleasure.
Yeah, certainly.